Welcome to the Deep Dive. Today, we're taking a close look at open surgical techniques in vascular surgery. You often hear about endovascular therapy these days, but open surgery remains incredibly important, offering long-lasting and effective solutions in many situations.
That's right. It's still the gold standard for durability in a lot of cases.
Exactly. Think of this as getting you the inside track on the essential tools and proven methods of this critical surgical field.
Yeah.
We're going to pull out the core principles, the fundamental how-tos, and the really key things to consider that make these procedures so vital.
And our source material for this deep dive comes from Rutherford's Vascular Surgery and Endovascular Therapy, specifically Chapter 61, Open Surgical Technique.
Great source. Yeah.
Our goal is really to extract the most crucial insights from this chapter, giving you a clear and valuable understanding of what these complex operations involve.
Okay, so let's get into it. What are the fundamental ideas? The bedrock of successful open vascular surgery?
Well, at its core, successful open vascular reconstruction comes down to a few key things.
Okay.
It's about choosing the optimal procedure.
Right time, right place.
Exactly. Optimal procedure at the optimal time for the patient, making sure the surgeon has the necessary access, the exposure, and then carrying out the operation carefully and efficiently.
Like a blend of timing, access, and skill.
You could think of it that way, yeah. Strategic timing, thorough access, and skilled execution.
And when you talk about choosing the right procedure, what are some of the main things you're looking at?
Well, a crucial aspect is carefully looking at what we call the inflow, the outflow, and the choice of any bypass conduit.
Inflow, outflow.
Conduit. Oh,
Yeah. You need to ensure there's a good supply of blood reaching the area.
Yeah, inflow.
Right. And a clear pathway for the blood to flow afterwards, that's the outflow.
Right.
And then if a bypass graft is needed, you need the most appropriate material. That's the conduit choice. So beyond the surgeon's hands, what about the actual physical tools? It's not just scalpels, right? It must be more specialized.
Oh, not at all. A standard set of vascular surgical instruments will include various clamps, needle holders, forceps, scissors, retractors, a whole range.
And the choice depends on?
It often depends on how large or small the blood vessel is and, where in the body you're operating.
Okay. Let's take clamps, for instance. What's special about them?
Well, vascular clamps have very fine ridges, serrations, on the inside.
For grip.
Exactly. To grip the vessel securely but gently, the goal is to minimize the risk of damage, of crush injury.
But there is a risk, right? You mentioned damage.
Absolutely. There's a risk of damaging the inner lining, the intima, or even tearing the vessel if a clamp isn't put on correctly.
Especially with plaque.
Yes, especially if there's plaque present or if you use too much force. That's why surgeons often feel the artery first. Palpate it.
To locate the plaque.
Yeah, to get a sense of where any plaque buildup is oriented, that helps position the clamp in the safest way.
So there isn't just one type of clamp?
Oh, no, there's a whole range. Different shapes, different angulations, all designed for specific anatomical locations and different vessel sizes. And you have clamps that completely block flow versus those that only partially block it, side-biting clamps.
Okay.
Plus, for delicate artificial grafts, there are special clamps with soft atraumatic inserts, cushioned jaws, basically.
To avoid damaging the graft.
Precisely. And for the really tiny vessels, think branches or vessels in the brain, we use even smaller, more delicate things like bulldog clamps or aneurysm clips.
Wow, okay. It sounds like a highly specialized toolkit. What about the other instruments? Needle holders, forceps, scissors? Are they just standard surgical tools?
Not quite. They're also specialized. Needle holder choice, for instance, depends on the needle size.
Bigger needles, bigger holders?
Generally, yes. Mayo-Hagar for larger needles, Castroviejo for the really fine ones.
And forceps?
Forceps need fine, non-crushing tips. DeBakey or Gerald forceps are common examples.
Gentle touch required again, I imagine.
Always. A gentle touch is essential to avoid crushing the vessel walls. There are even specialized forceps, like Gerald forceps, particularly useful for vein bypasses down in the lower leg.
Okay. And scissors? Different types there, too?
Yep. Metzenbaum and Church scissors are often used for general dissection around blood vessels. Stevens tenotomy scissors are finer for the smaller tibial vessels, and pot scissors have a specific angle. For precisely shaping and enlarging the openings made in arteries or veins, arteriotomies or venotomies.
Right.
And don't forget right angle clamps. They're crucial for getting around vessels and branches safely.
Okay, so we've covered holding, cutting. What about visibility? Getting a good view must be critical. Retractors.
Exactly. Self-retaining retractors are often preferred.
Why self-retaining?
They provide stable, consistent retraction without someone having to constantly hold them and apply pressure. It frees up hands and avoids excessive force.
Makes sense. Any specific examples?
Sure, the OmniFlex retractor system is common in open aortic surgery. Think of it like adjustable arms with different blades to hold back the abdominal wall or delicate structures.
Okay.
The Bookwalter retractor is another option, often used for abdominal aortic and iliac exposures, sometimes in less invasive approaches too.
And for smaller areas, neck, arms, legs.
For those, there are single-instrument self-retaining retractors, things like the White Laner, Adson cerebellar, Miscamon for heavier patients, spring retractors for below the knee, Gelpy retractors, each suited for specific spots.
Got it. So the vessels are exposed, tools are ready. What about the glue and the pipes? Sutures and grafts. Let's start with sutures.
Right. For vascular work, you generally need non-absorbable sutures.
Meaning they don't dissolve.
Exactly. They need to provide lasting strength as tissues heal, or indefinitely for artificial grafts.
And the type.
Monofilament sutures, single strands, are standard for most reconstructions. Braided ones might be used sometimes, maybe for tying off small vessels.
Okay.
And they often come double-armed.
A needle on each end.
Yes, which lets the surgeon stitch continuously back and forth after the first knot.
What are they made of? Must be strong stuff.
Absolutely. Common materials include polypropylene. You might know brand names like Prolene or Surgipro. Very popular, strong, easy to handle. Interestingly, they're often moistened with saline before tying.
Why is that?
Helps prevent tiny fractures, makes them tie down smoothly. Then there's polypester, which has a coating to reduce drag through tissue.
Easier to pass the needle.
Right. And PTFE sutures are designed specifically to minimize bleeding from needle holes, especially in PTFE grafts. But they need really secure knots.
And the size varies.
Definitely. Needle size, suture thickness, all chosen based on the vessel size.
Okay. And the pipes, the grafts, when do they come into play?
Grafts are essential when a section of blood vessel is diseased beyond repair or needs to be bypassed completely.
Different types for different places.
Generally, yes. For the thoracic aorta, polyester grafts are common.
Okay.
For the abdominal aorta and leg vessels, both polyester and PTFE are used.
PTFE, like Gore-Tex.
Kind of, yeah. It's a similar base material. But often, for smaller artery reconstructions, the patient's own vein, an autogenous vein graft, is the best choice.
Why is that?
It's living tissue, very compatible, lower risk of infection compared to artificial materials. It tends to work better in the long run for smaller vessels.
Right. Okay. So we've got the foundations, principles, tools, materials. Now, let's talk about putting it all together, the basic surgical techniques.
Well, the fundamental flow usually involves getting access to the vessels.
Exposure.
Right, exposure. Then gaining control of blood flow, proximal and distal control.
Clamping, basically.
Clamping or other methods, yeah. And finally, performing the specific repair or reconstruction.
Which could be?
Things like removing clots, thromboembolectomy, cleaning out plaque and endarterectomy, making and closing incisions in the arteries, arteriotomies, or constructing bypasses or replacing segments using grafts.
Okay, let's start with that first step, getting to the vessels, exposure and dissection. What are the key principles there?
The main idea is finding the most direct, efficient route to the target vessel.
How do surgeons decide where to cut?
They use anatomical landmarks, the feel of the tissues, where the pulse is. For instance, doing a leg bypass, you need the inflow pulse palpable right there in the surgical field.
Makes sense.
Vessels are usually found between muscle bellies. If you find you need to cut through a lot of muscle, you might rethink the approach.
Gentle handling important.
Crucial. Gentle handling of skin and soft tissues helps prevent wound healing problems. Also, tiny lymphatic vessels need careful handling, ligation and division to prevent fluid buildup, avoiding cautery near lymph nodes.
Okay. And once you find the vessel sheath?
You open the sheath, retract the outer layer, the adventitia, and gently separate surrounding tissues, staying close to the artery wall to be in the right plane.
Yeah.
Then you carefully free up the vessel all the way around, skeletonize it, and pass a soft celastic loop or umbilical tape around it.
For control.
For gentle traction and manipulation during the rest of the procedure. Gentle tension is key.
Now, what about repeat surgeries? Second time in the same spot. Sounds tricky.
You're absolutely right. Reoperating is challenging. Scar tissue. It just obliterates the normal planes.
So how do you navigate that?
Sharp dissection is really important, being extremely careful to identify any side branches. Sometimes a small, sharp scalpel blade, like a number 15, is better than scissors for carefully carving through the scar tissue away from the artery wall.
Sort of shaving the scar away.
Kind of, yeah, at a shallow angle. And the principle of known to unknown dissection is vital.
Meaning?
You start dissecting where there isn't scar tissue, where the anatomy is normal and predictable.
Okay.
And then carefully work your way towards the scarred area. And getting control of blood flow upstream outside the scar is critical for safety.
Any particularly risky areas in reoperation?
The groin area during repeat femoral artery surgery is a big one. The profunda femoris artery, a major branch, is vulnerable.
So how do you protect it?
Often you start lower down, finding the superficial femoral artery where there's less scar, then dissect inwards and upwards. Finding the femoral vein helps identify the right plane. Once you get control of the common femoral artery higher up, near the inguinal ligament, you can reverse the dissection downwards. You can usually tell where the profunda branches off by the change in vessel size.
And controlling the profunda itself in scar?
Special techniques might be needed. Maybe a vessel loop passed carefully under the superficial femoral artery, or sometimes using a balloon catheter inside the common femoral artery to temporarily block flow into the profunda, especially in really dense scarring.
Okay, vessels exposed. Before clamping, you mentioned thinning the blood anticoagulation. Why is that done?
It's typically given just before clamping to prevent clots forming thrombosis or bits of plaque breaking off embolization because the blood stops moving in that clamped segment.
Standard practice.
Very standard. Usually unfractionated heparin given IV a few minutes before clamping.
And you monitor it.
Yes, often with a test called the activated clotting time, or ACT. The target is usually over 250 seconds.
Important point there. Lack of blood flow after surgery isn't always emboli.
Right. While embolization is common, especially after aortic work, inadequate anticoagulation during the procedure can also contribute to limb ischemia.
And if someone can't have heparin?
If they've had a reaction like heparin-induced thrombocytopenia, alternative anticoagulants like argatroban can be used.
Okay. Now, the moment of truth stopping the blood flow. Vessel control. Clamps seem like the obvious choice.
They often are. Ideally, you place clamps on a disease-free segment of artery.
But what if it's all diseased?
Then you try to find the least diseased spot. Feeling the artery against a right-angle clamp can help locate plaque, often on the back wall. If there's a significant plaque where you want to clamp, you might need to dissect higher up to find a better spot, like going from the common femoral up to the external iliac artery.
And if clamping a diseased artery is unavoidable?
You try to position the clamp so the softer part of the artery wall opposes the plaque to minimize the risk of cracking it or tearing the wall.
And in really severe cases, extensive plaque calcification.
Sometimes you might need much higher control, like clamping the aorta above the renal arteries if infrarenal or suprarenal clamping just isn't safe or possible.
What about blocking the artery from the inside? Balloon occlusion, when's that better?
Balloon occlusion is a great option when external clamps might be too risky.
Like when?
If plaque goes all the way around the artery, or takes up more than half the diameter, clamping could easily fracture plaque or tear the wall.
So you insert a balloon instead.
Exactly. A compliant balloon catheter, like a Fogarty embolectomy catheter, or sometimes a non-compliant angioplasty balloon. Insert it, inflate it, blocks flow from within.
Safer for the artery wall.
Potentially, yes. There are even specialized occlusion balloons for emergencies like ruptured aortic aneurysms.
Where else might you use balloon occlusion?
Useful if the external iliac artery is heavily calcified way up high, or for isolating specific vessels during complex aortic repairs, maybe the right iliac during a left-sided approach, the profunda during a false aneurysm repair, or renal or visceral vessels during thoraco-abdominal aneurysm surgery.
I also see vessel loops listed for control. How do they work?
Vessel loops, usually soft celastic ones, are ideal for controlling smaller to medium-sized vessels.
Like the profunda or popliteal?
Exactly, or smaller side branches. They're gentler than clamps.
Any downsides?
You have to be careful not to pull too hard. That can still cause trauma. There's a Potts double loop technique to distribute pressure.
Okay.
Also, having loops for both inflow and outflow control simultaneously can sometimes get in the way of the actual repair.
So what's the alternative?
A good option is a loop on one side and a small, low-profile clamp, like a Yassergill clip or a bulldog clamp on the other side. Less bulky.
And pneumatic tourniquets. like for knee surgery.
They have a role in vascular surgery too, especially for extremity work, like bypasses below the knee and for popliteal reconstructions.
What's the advantage there?
Minimal exposure, dissection, and handling of the arteries themselves might reduce spasm or injury risk to those small tibial vessels.
How's it applied?
Around the thigh or below the knee, over padding. Elevate the leg, wrap it with an S-march bandage to push blood out, then inflate the tourniquet.
To what pressure?
Usually around 250 mmHg or 100 mmHg above the patient's systolic pressure.
Anything crucial before inflating?
Yes. Make sure any bypass graft is lined up correctly and its orientation marked before inflation. Can't easily adjust it once the field is bloodless.
Does it always work perfectly?
Not always. Sometimes you still get bleeding. You might need to increase the pressure slightly or add a clamp on the profunda. And if arteries are very calcified and incompressible where the tourniquet is, it might not stop all distal bleeding.
Okay. Last couple of control methods, rheumal tourniquets and internal occluders.
Rheumal tourniquets. Well, they can work, but risk damaging plaque-filled arteries. Maybe most useful nowadays during endovascular aortic procedures if there's bleeding around a large sheath insertion site. Pediatric rheumels are good for gently securing carotid shunts.
And internal occluders.
Devices like Florister occluders can be used for small, heavily calcified arteries, but the surgeon needs to be comfortable with them, and it's critical not to oversize them, which could injure the vessel lining.
Right. Okay. Control established. Let's move to repairs. Thromboembolectomy, removing clots. Sounds vital.
Absolutely fundamental skill, often the key treatment for acute limb ischemia, sudden blockage.
How does it work?
Basically, you use a specialized balloon catheter. A Fogarty catheter is the classic example to physically pull the clot out of the artery.
Whether it formed there or traveled from elsewhere.
Exactly. A thrombus forms locally, an embolus travels. Often, thrombus forms around an embolus due to stagnant flow, hence thromboembolectomy.
What does it achieve?
Restores blood flow quickly and lets you examine the clot to see what it is.
Key things to get right.
Choosing the right spot and shape for the arteriotomy, the incision into the artery, selecting the right catheter, minimizing blood loss and injury, steering the catheter correctly, and making sure you get all the clot out.
How do you know you got it all?
Good pulsatile back bleeding is a sign, but you also want to feel a thrill of liberation in the downstream vessels. Sometimes we use a Doppler probe intraoperatively too.
You mentioned different catheters. What are the variations?
Lots of variety. Standard balloon catheters range in size, typically 2 to 7 French. Balloon size varies too.
How are they inflated?
Usually saline, except the tiny 2 French uses air for easier deflation.
Different sizes for different arteries?
Yep. 2 or 3 French for tiny pedal or hand arteries or tibials. 4 or 5 French for femoral popliteal iliacs. 6 or 7 French maybe for aortic grafts or large saddle emboli.
Any other types?
Venous thrombectomy catheters have larger low-pressure balloons. Latex-free options exist. Some are wire-guided for use with fluoroscopy.
Fluoroscopy, X-ray guidance.
Yes. And there are special catheters for really adherent sticky clots. One has a spiral wire tip. Another has a wire coil stripper for clots inside synthetic grafts. Very important not to use that one in native vessels.
Got it. Let's talk technique. Where do you make the arteriotomy?
Can be proximal or distal to the clot. Depends on exposure, clot location, ease of closure.
Common spot.
For lower limb ischemia, the common femoral artery in the groin is often ideal. Easy access, easy closure, sometimes even local anesthesia.
But you might need to go closer.
If thrombectomy from the groin isn't successful, yes, an incision closer to the blockage might be needed. And adequate anticoagulation beforehand is crucial.
And the shape of the incision? Across or along the vessel?
Depends. Transverse across is less likely to narrow the artery on closure, often preferred for emboli. Easy interrupted suture closure.
Okay.
Longitudinal along the vessel might be better if there's underlying plaque or thrombosis. Allows for potential endarterectomy or patch widening. Can be part of a bypass anastomosis start point. May need a patch closure to avoid narrowing.
Minimizing blood loss and preventing vessel injury seem paramount.
How? For blood loss, often pass the balloon proximally first, just short of the lesion, inflate, pull back initial loose clot. Then, after crossing the lesion, allow brief, vigorous bleeding to flush debris. Repeat until good flow and no more clot on 2 passes.
Controlling bleeding during catheter passage.
Silastic loops snugged down can help. For grafts, maybe manual compression. If proximal pass bleeds too much, a soft jaw clamp Gently applied can control it while you withdraw the balloon.
And preventing injury. That sounds critical.
Absolutely. Can happen from the balloon, the tip, overinflation, forceful insertion, or withdrawal. Need to stay intraluminal.
Not digging into the wall.
Right. Gentle technique, watch for resistance. Overinflation or yanking back can shear the intima, cause dissection, rupture, pseudoaneurysm.
So how to avoid that?
Choose the right catheter size. Test the balloon first. Limit inflation fluid. Measure externally to estimate distance. Inflate gently during slow withdrawal until you feel slight friction. Then no more inflation at that point. Maintain that friction. Adjust inflation dynamically as vessel size changes.
Does back bleeding guarantee success?
Not always, especially down in the tibials. Catheter might go down one branch, miss another.
So you check afterwards.
Definitely. Careful exam of the reperfused limb, intraoperative angiogram if flow isn't satisfactory, or routinely before closure to confirm completeness.
You mentioned fluoroscopy X-ray guidance. How does that help?
It's a valuable tool, used from the start or selectively. You can see the balloon inflate, do an angiogram first for a roadmap.
See the anatomy and the clot.
Exactly. Watch the catheter move, know exactly where it is, see if it goes down a side branch. Judge inflation needed by watching the balloon fill under fluoro.
Any tricks with fluoro?
Use diluted contrast for inflation so it deflates quickly. Can detect stenosis if the balloon shape changes. In the tibials, you can actively steer the catheter by bending the tip, rotating it. Can even use a tube balloon technique or a guiding catheter to direct the balloon into specific tibial vessels. Over-the-wire balloons also allow more control.
Main advantages of fluoro.
More controlled procedure, visual confirmation of success, plus the opportunity for immediate endovascular intervention angioplasty, stenting if you find an underlying lesion causing the problem.
Okay, moving on. Endorectomy, cleaning out a plaque. Where is this commonly done?
Very common for carotid artery disease in the neck, often the sole treatment there.
And elsewhere.
Can be done on the common femoral and profundifemoris arteries in the groin, sometimes alone, sometimes combined with endovascular work up or downstream. Can be part of a bypass anastomosis. Can even be done during endovascular aneurysm repair access.
What exactly is removed?
The thickened inner layers, intima and intermedia, leaves the outer media and adventitia. Goal is a smooth transition where the plaque removal stops, sometimes needs tacking sutures to hold the edge down.
When is it not done?
Generally contraindicated in aneurysmal arteries, the remaining wall would be too weak.
Different types. You mentioned open, semi-closed.
Open, semi-closed, eversion, orificial extraction, several variations.
Let's start with open endarterectomy, the standard approach.
Often, yes. Make a longitudinal incision over the plaque. Carefully separate the plaque from the artery wall.
Finding the right layer seems key.
Absolutely crucial. You hold the adventitia edge, develop the plane between plaque and outer media adventitia. A freer elevator helps push the outer layers away from the plaque.
Work all the way around.
Yes, circumferentially. Minimal resistance in the correct plane. Proximally, plaque usually feathers out or is cut flush.
Distal end can be tricky.
Can be. If it feathers into normal artery, you adjust the plane slightly for a smooth transition. If it extends down with no clear end, free it up. Gentle traction might help. If you have to cut it cleanly, leaving a shelf, then suture tacking is important. Stitch the remaining intima plaque edge to the adventitia beyond the endarterectomy site to prevent it lifting up when flow returns. Might need several interrupted sutures.
Proximal tacking needed?
Less often, but consider it if the plaque edge is thick or protrudes, and meticulous inspection afterwards to remove any loose fibers or debris is vital. Clean surface before closure.
What about semi-closed endarterectomy, avoiding the long incision?
That's the idea. Open the artery proximally and distally to the plaque. Dissect, transect proximally, core it out with ring strippers, transect distally, remove the core.
2 small closures instead of 1 long one.
Right. Variation is 1 incision, crush the plaque at the other end. Maul ring cutters allow sharp remote transection or remote endarterectomy.
It's the advantage.
The endpoint isn't under direct vision, can be unpredictable.
How do you manage that?
Often combined with angioplasty, maybe stenting, to secure the distal endpoint. Intravascular ultrasound can help confirm you're in the right place. Used successfully in external iliac and superficial femoral arteries.
And aerogen endarterectomy, popular for carotids.
Yes, increasingly so. You transect the artery completely, then turn the wall inside out, avert it.
Like peeling a sock off.
Kind of. Hold the outer layers, gently lift them from the plaque core. Develop the core circumferentially, hold it firmly. As you extract the plaque, roll the adventitia back, push the artery forward, plaque separates cleanly, transect at the right endpoint.
Requires mobility.
Yes, need enough mobilization to avert and reattach. Often involves transecting the internal carotid, removing plaque from the bulb and proximal ICA, then reattaching it. Some studies suggest lower restenosis rates with avers for carotids.
Lastly, orificial and extraction endarterectomy for branch openings.
Exactly. Modification of aversion for disease right at the orifice of a branch. Expose the orifice from inside the main vessel. Push the artery distal to the plaque towards the orifice to extrude the plaque.
And extraction.
Using a loop or instrument to grab and pull out plaque extending just beyond the orifice. Generally for short segment disease.
Endpoint issues again.
Yes, not under direct vision. Careful assessment after flow restoration is key. Especially important for the profunda femoris orifice during femoral endarterectomy. If plaque goes deep into the profunda, need direct inspection, maybe extend the incision and patch.
Okay. If endarterectomy extends into both SFA and profunda.
Can suture the adjacent walls together, syndactylization, create a common channel, then patch that single opening, avoids patching two separate arteries side by side.
We've opened and cleaned. Now, closing the arteriotomy, primary closure or patch?
Depends. Artery size, incision direction shape, amount of atherosclerosis, all factor in.
When is primary closure okay?
Most transverse arteriotomies, even in tibials, can be closed primarily. Longitudinal ones, too, if the vessel isn't diseased and can tolerate a slight narrowing like common carotid or femoral. Most expeditious is a continuous running suture. Get all wall layers. Trim loose adventitia. Needle goes intima to adventitia, inside to outside.
Why inside out?
Avoids pushing plaque inwards if you go outside in, prevents dissection thrombus. Continuous works well for healthy vessel, endarterectomized segments, grafts, veins. Even bites, watch depth advancement to avoid narrowing.
When might interrupted sutures be better?
If there's plaque at the arteriotomy edge or in smaller vessels. For transverse cuts, placing all interrupted sutures then tying allows good visualization, prevents purse stringing in small arteries. Still intima to adventitia.
When is a patch definitely needed?
If primary closure would cause significant narrowing, good data supports it for better carotid endarterectomy results.
Technical factors favoring a patch.
Artery, less than 5 millimeters, significant plaque at the site, jagged incision, tortuous artery, loss of wall area. Also non-technical factors like high risk for restenosis, hyperlipidemia, smoking, female, prior restenosis.
Advantages of patching.
Needle always goes inside out, avoids pushing plaque in, allows good purchase and patch an artery without compromising lumen. Need to choose appropriate patch width, though too wide causes redundancy, invites thrombus.
Patching techniques.
Simplest, suture at each apex, run both sides to meet, or the parachute technique.
You mentioned that earlier.
Right. Start near apex, don't tie. Suture several bites each side. Hold patch away, then gently pull sutures to parachute it down. Wetting suture, wiggling ends helps tighten smoothly. Great for deep spots.
Okay. What about joining completely cut vessels, end to end?
Depends on size and pressure. Small branches, simple tie or clip. 3 5-millimeter vessels. Suture ligature, especially if short stump. Larger vessels, running non-absorbable suture.
Low pressure versus high pressure.
Low pressure, large vein, distal artery end, simple over and over continuous stitch, usually fine for hemostasis. Proximal artery and high pressure single row might not be enough, especially like an aortic stump after infected graft removal.
So 2 rows.
Often preferred. First row, horizontal mattress sutures, continuous or interrupted. Second layer, continuous over and over. First row reduces tension on the second.
Small vessel, end to end.
4-quadrant technique is good. Suture at toe heel of spatulated ends, run each to middle, tie. 4 fixation points prevents constriction.
Finally, the big ones. Replacement and bypass procedures. When are these done?
For occlusive disease, aneurysms, trauma, replaces or bypasses the damaged blocked segment.
Key considerations.
Need adequate inflow, good blood supply coming to the graft, adequate outflow, clear path for blood leaving the graft, and the right conduit choice, vein or synthetic.
For leg bypasses occlusive disease, how are grafts usually connected?
Typically endoside for both proximal and distal anastomosis.
Why endoside?
Preserves existing circulation. Proximally allows flow down native artery and into bypass. Distally allows retrograde flow into branches below the anastomosis.
But sometimes end to end.
Yes, if the native artery is too diseased, or for aneurysms where you replace a segment, often end to end then, or sometimes bypass an aneurysm enticide proximally and distally, then ligate the aneurysm itself.
Let's look closer at the end-to-side anastomosis. Important details.
Align vessels carefully. No twists, kinks. Technical perfection here is key. Incision on back of graft parallel to axis prevents buckling.
Arteriotomy length. How long to make the hole in the artery?
Ideal length debated. Recommendations vary. 1.2 to 2 times graft diameter is a common target. Too short gives a sharp angle. Too long, no proven benefit.
Spatulation, cutting the graft in.
Yes, cut the graft end, slit the posterior aspect to match arteriotomy length. Spreading it open spatulation minimizes narrowing at the connection.
Techniques for sewing it. Anchor versus parachute again.
Yes. Anchor technique. Suture at heel, tie, stabilizes. Suture one side heel to toe, then halfway down other side. Complete with other end of heel suture, or start another at apex, run both sides to heel. Good for superficial, larger vessels. Allows traction, counter-traction.
And parachute.
Heel apex sutures placed but not tightened initially. Start sewing near heel center. Hold graft away, place several bites. Then gently pull sutures to parachute graft down. Wet suture, wiggle ends. Great for small or deep vessels where initial heel-toe visualization is tough.
Okay, what about end-to-end anastomosis? When and how?
Used for replacing segments, aneurysm, trauma, composite bypasses, or when preserving native flow isn't critical. Technique depends on size mobility.
Large, mobile vessels.
Can often cut ends perpendicular. Techniques allow rotating vessel for easier sewing, like placing anterior-posterior stay sutures, sewing front, flipping 180, sewing back, or Correll triangulation, 3 segments.
Non-mobile segments.
Like aorta.
Usually sew back wall first. Continuous parachute or anchor depending on depth preference. Deep bites essential for aorta needs strength.
Small vessel end-to-end.
Spatulation is essential to avoid narrowing. Cut obliquely, extend cut posteriorly. Anchor suture at heel center, run each side. Creates oblong shape, more forgiving than a circle.
Side to side, rarely done. Much less common. Main use. Radiocephalic AV fistula for dialysis. Sometimes a discal AV fistula added to infraguinal prosthetic bypass to improve patency by lowering outflow resistance. Also may be for second anastomosis in sequential bypass.
Technique?
Dissect vessels, lay adjacent without tension. Longitudinal incisions where walls touch. So back wall first, usually 6-10 millimeters long.
Finally, these adjunctive techniques for infraguinal bypasses, helping things work better down low.
Exactly, especially for challenging tibial bypasses, often with prosthetic grafts.
Like the T-junction.
If using vein graft with a side branch, transect main vein near branch, slit posterior wall to incorporate branch into anastomosis heel, creates T-shape, minimizes sharp angle narrowing.
Saphenofemoral junction vein cuff.
Using the very top of the saphenous vein where it joins the femoral, including a rim of femoral vein, gives a large venous hood for anastomosis, helpful if artery is thick or vein small.
Distal vein patch techniques. Interposing vein between graft and artery.
Yes, several variations, especially for prosthetic to tibial bypasses. Miller vein cuff, vein opened, sewn to arteriotomy, ends sewn to form oval cuff, graft sewn to cuff, can have turbulence issues, tricky and tight spots.
Taylor patch.
Longer arteriotomy, longer patch, U-shaped slit in graft underside, graft heel to proximal arteriotomy, anterior graft incised. Vein patch closes elliptic defect, but exposes native artery intima to graft proximally.
St. Mary's boot.
Similar start to Miller, but corner of veins sewn to arteriotomy apex, toe. Redundant vein excised obliquely, posterior collar incised, aims for compliant collar, avoids artery graft contact, maybe better hemodynamics, technically demanding.
Distal vein patch, Lenten patch.
Shorter arteriotomy, less vein needed. Vein segment open, sewn to arteriotomy as parachute. Graft then sewn to longitudinal opening in proximal part of patch. Vein tissue interposed between graft and entire artery circumference at the toe.
And lastly, distal anastomotic arteriovenous fistula, connecting artery and vein.
Added to distal anastomosis sometimes to improve graft flow with poor runoff. Dardick pioneered with umbilical vein grafts, common ostium-reduced thrombosis, can be added to distal vein patch bypass too if runoff is bad and no good vein conduit. Open target artery and vein, suture opposing walls, common ostium, vein patch sewn to common ostium, graft sewn to vein patch.
Wow. That covers an immense amount of detail. It's incredibly clear that open surgery requires deep knowledge, precision. It's intricate work.
It really is. Open techniques are absolutely vital. It demands a solid grasp of the tools, materials, basic techniques, and these more complex reconstructions. Precise exposure, meticulous control, careful anastomosis construction, they're all paramount.
And these adjunctive techniques show how things are always evolving to improve results, especially in tough situations like those below-the-knee bypasses.
Exactly. Constant refinement.
So for you, our listener, you've now gained, I think, a really valuable overview of the core principles and the practical methods of open vascular surgery, hopefully moving far beyond just a surface-level understanding.
And that complexity and evolution brings us to a final thought. Considering the continuous advancements we see in both open surgical and endovascular techniques, how might that gold standard or the best practice for different vascular conditions continue to evolve? What factors do you think will be most influential in shaping those future decisions?